Good afternoon, everyone. My name is Morgan Gargiulo from the New England QIN-QIO, and I will be your moderator for today's webinar, Immunization Innovation Protecting Public Health. Before we get started, I wanted to go over a few housekeeping items. This call is being recorded for training purposes, and I'll provide you with details on accessing the recording at the end of the webinar. As you heard, the phone lines are currently on mute for the duration of the presentation. If you haven't yet downloaded the slides, I'm going to put a link into chat where you can find them. We will be taking questions throughout the presentation via the chat box at the bottom right of your screen. If you could please make sure to send your questions to all participants so that Dr. Bratberg can keep up with the incoming questions, and he's going to do his best to answer them in real time. So for now, I will pass it over to Russ Cooney to introduce our speaker and get us started. Russ?
Good afternoon, everyone. Before I introduce Dr. Bratberg, I just wanted to reiterate that during the presentation, Dr. Bratberg will be asking questions of the audience, so we would appreciate your responses through chat. Okay, it's my pleasure to introduce today's speaker, Dr. Jeffrey Bratberg. As a public health pharmacist and academic collaborations officer at the Rhode Island Department of Health, Dr. Bratberg works with staff members and University of Rhode Island faculty to establish collaborative public health projects suitable for student participation and enrichment, including immunization projects. As professor, he co-coordinates all of the infectious disease courses at URI, including an elective class focused on communicating vaccine benefit to the vaccine-hesitant population. As an advocate, he spearheaded a successful effort to authorize pharmacists' ability to immunize by protocol or prescription in collaboration with the Rhode Island Department of Health, the Rhode Island Pharmacists Association, and the Ocean State Immunization Coalition. Since then, he has taught the American Pharmacists Association Immunization Certification Program to hundreds of practicing pharmacists and student pharmacists and delivers educational programs on adult immunization promotion to pharmacists, nurses, and physicians. Dr. Bratberg has also worked to educate the public on emerging infectious disease and novel vaccines. Most recent work has been with Zika and Ebola viruses. Thank you again, Dr. Bratberg, for being with us today. The floor is yours.
Thank you, Russ.
Russ, if you could actually pass the ball to Dr. Bratberg. Russ, did you hear me?
Yeah, for some reason it's not.
If you right-click on his name and select Make Presenter.
All right.
Or if that's not working.
Have the moderator switch it, please.
Yeah, Jennifer, if you're on, can you please move the ball from Russ to Dr. Bratberg? We're having some computer difficulties. Excellent. Thank you, Dr. Bratberg. You should be good to go.
Okay. Thank you very much. And again, I look forward to an interactive talk here. We've got some diverse topics to talk about. We're only going to touch on some of them just to increase your awareness and appreciate your focused questions here. So we do want to hear from you. I don't have any conflicts of interest to disclose. And again, the objectives are to talk a little bit about new vaccines, vaccine formulations, and how they're delivered. We'll look at state-level policy changes and how they affect vaccination rates, and some new research on vaccine communication techniques for vaccine hesitancy. So as I talk about some of the, start with some basics about vaccinology, if you have things that you think about, what's ideal in a vaccine? What do you, what would you like in terms of public health or you as an individual? One obvious one is you want your vaccine to be safe, but what other qualities are interesting to you that would be ideal? So everyone can go to cdc.gov/flu or FLU to find out the flu view. This comes out every week. As you see, it's a weekly influenza surveillance report by the Influenza Division. And in many areas of our region and the country, we are in an epidemic. We are above the epidemic threshold. The if you haven't seen these graphs before, you can see the week is on the bottom. On the other axis, on both axes, it's number of positive specimens and the percent positive. The percent positive is that black line there, and you see percent positive flu A and flu B. As with most seasons, flu A dominates. These are the major strains, and just a little bit of flu B. We'll typically see flu B in green there at the end of the year. So that's the kind of typical pattern. Now, when we break it down into subtyping, different than the past few years, we're dominant with an H1N1 PDM09, which means PDM is pandemic. So the pandemic strain seems to be dominating this year, and it has in the past years. And the second most common is H3N2. H1N1 typically affecting younger populations, H3N2 more deadly for older populations. So you can see this is a lot of lines here. It's each one of the seasons, and again, this is percent visits for influenza-like illness, or ILI, from a surveillance network, and many areas of our region are involved in this. Red line with the red triangle, that is the 2018-19 season, and you see once we're above that, that a little bit more than 2% of visits for ILI, we are in an epidemic. If you look at last year was 2017-18, you saw that we peaked a little bit at this time, it went down a little bit. What we expect, it'll continue to rise. I think what's important too is you see the relative size and duration of last year's season. Last year's season was one of the most deadly influenza seasons on record. 84,000 people died last year from a vaccine-preventable illness. And there's a lot of factors that go into that, and one of the reasons that we're constantly striving to improve our influenza vaccination prevalence. Here's a map of the U.S. You can see widespread is most of the states in our region and most of the country. You can go to the next one here. We look at the age selection here. So I blew it up. It's a little fuzzy there, but it's almost hard to read. And this, again, this is lab-confirmed influenza hospitalizations. And so you see the elderly population, 65 plus, leads there, and the other age groups are on the bottom, overall increasing. This is also, again, we had 84,000 total deaths, but one of the deadliest flu seasons on record for pediatric deaths, a reportable disease, and you saw overall it was 185 deaths, which is, I like this graph because it's nearly double what it was in 2015 or 16. So we still need to be prepared here. Thank you for the person who said lifelong immunity in a single dose. That's good. You know, that's something that we don't have with flu vaccine yet. We'll talk about some new vaccines here. Anyone else wants to type what they think about ideal vaccine characteristics? Lifelong immunity in a single dose. And we almost have that with measles, mumps, rubella. We almost have that with hepatitis A, so we get 2 doses of either of those vaccines. Hep B, 2 or 3 doses. So we talked about safety, immunity, maybe convenience. You probably all know people who are afraid of getting influenza. Availability, difficulty getting the new shingles vaccine. Lots of demand. It's important that when we say the new vaccine comes out, or a new vaccine form comes out, non-injectable options for kids. So we just saw the reintroduction of live attenuated influenza vaccine. The intranasal form was re-approved from the Advisory Council on Immunization Practices. And again, kids don't like to be injected. There's also adults that don't like injections. There's forms of influenza injections. It's an intradermal injection. Maybe lack of, we want permanent immunity. We want minimal side effects. We want easy to deliver, low cost would always be good, sort of what we see in healthcare. So let's talk a little bit about, we talked about ideal qualities of vaccines. Let's think about which new vaccine or vaccine technology would you most like to see and why? So maybe that's that non-injectable option, maybe it's a few others. So when we think about immunity, it's complex. This is a simplified slide of innate immunity on one side and adaptive immunity on the other. And lots of different cells. Innate are things that we really can't change or augment very easily with vaccines. And so you have sort of, depending on what the invader is, what the pathogen is, if it's a virus or if it's a bacteria, it either gets engulfed or it gets destroyed by natural killer cells or NK cells there, or the pathogen is presented to an APC or an antigen-presenting cell and stimulates adaptive immunity, which again leads to lifelong immunity from our memory cells. You see the B cell on top, the production of antibodies, T helper cells or CD4 cells, and CTL cells, which lyse target cells that are either the bacteria themselves, the protist itself, or it's a cell that's infected with virus, and so to lyse that cell. So scientists, for as long as we've known the immune system, the more we know about it, typically immunologists tell me, the more we don't know about it, the more we don't know how this works. Great, less evasive, lower strength for those with immunity condition, right. So the thing is, you can use attenuated bacteria or attenuated viruses to help healthy people develop a more natural and longer-lasting immune response. But if you're immunocompromised, it's more dangerous. So balancing sort of what's the best way to activate the immune system. And developing vaccines is really, there's a lot of steps. So pre-licensure, you have to figure out what's the disease burden. So we're focusing on flu today because it is flu season, and we have, again, thousands and thousands of deaths and hundreds of thousands of excess hospitalizations. Again, most of them vaccine preventable, even at a 60% effectiveness percentage. Now, is it feasible? And so that's sort of where we are with new vaccines. Is it feasible? Where's the basic vaccine research? Let's look down at the cellular, molecular, and DNA level. Once you have a candidate vaccine, you have to manufacture it. Some of the manufacturing processes are very expensive and novel, require many more steps than developing drugs. And then you have the typical drug or vaccine development phases here, phase 1, 2, and 3. And then a risk management plan. I mean, if you develop a medication and you prove it's better than the previous medication or placebo, you'll examine safety in phase 4 trials, but there's many more vaccine safety surveillance systems to make sure that we aren't causing more harm than good with vaccines. So here's one example of an article that came out last year. Do we have a large national and global burden of disease with HIV? Absolutely. We have many dozens of medications that are effective, but we can't cure it. When we think about an ideal vaccine for HIV, we'd want to have two different forms. We want a preventative form so that you get vaccinated, and if exposed, you don't develop disease like measles. Or do you have, do you have a vaccine that treats HIV? And so that's what this is it's epitope-based vaccine design. So basically, since HIV by design evades and infects the immune system, it's really difficult to design a vaccine. And since HIV was discovered, many decades of research have gone into developing a vaccine. And I think that this is one of the ways vaccine design and novel design. The fusion peptide is a preserved protein that doesn't change. So again, when we think about flu, we design vaccines against changing surface antigens that stimulate immunity. So if you're going to design a vaccine that eradicates all of HIV, you need to have a vaccine that causes the body to develop antibodies towards conserved regions. So we don't know how to do those conserved regions until we start doing 3D crystallography, looking at the epitopes, essentially mapping a lock so that we can design a very specific key. The more specific the key, the less chance of unintended effects, adverse events, things like that. So I think that this vaccine is going into phase 1 human trials, and this actually was done in human trials. Again, it's advancing through the phases. And the key in the title is neutralizing diverse strains, is that if we have to spend a lot of wealth to just identify whether a person is a candidate for a particular drug or vaccine, we're not really protecting the public health that is intended for vaccines. So vaccine design, I think, has really been advanced here. And we have vaccines in development and in practice now, or I should say in human trials for malaria and TB. So the three largest killers of humans, malaria, some of the largest killers or infectors of humans, TB, malaria, and HIV, especially in the developing world. We now have vaccines. So instead of having people take medicines for life that have side effects and have to be distributed and monitored, you can give vaccines and treat or cure or prevent those diseases. So we look at some of the ways that we can design vaccines. It's mapping the proteins and designing specific antibodies. You can do nanoparticle vaccines against infectious diseases. So maybe we can make the immune system actually work better. So we can coat these nanoparticles, you see on the right there, antigens in the targeting molecule, and the nanoparticles get taken up by our antigen-presenting cells. And you can increase innate and adaptive immune responses. You actually make your innate immune system work better when pathogens, and when we say work better, meaning use less energy, you never have symptoms, it's not just an attenuated disease or keeps you out of the hospital or keeps you from dying. You literally have no idea you have disease and may not even be transmitting it. So those are the kinds of things we have here. I like the questions here. How do you recommend approaching a conversation with an individual who's resistant to flu vaccine? We're going to talk about vaccine hesitancy in a little bit. I like the lower cost of life-saving injectables. The vaccine made me sick. I'll never get it again. Yeah, it's, negative information travels faster than positive information. And what's difficult about vaccines is we live in a culture where a medication is given and you feel better, or whether medication did it or not, you have that connection. You use a vaccine, it's intended for you to stay healthy. And so you don't go around and say, I'm healthy today because I got my vaccine. You say, my arm hurts, I'm feeling fatigued, and it's important that we communicate to people that there are side effects. It's not side effect free. It's not a perfect vaccine, but it does keep you out of the hospital. It does prevent death, especially in vulnerable people, and protects the people that you love around you. So I think that's one way to communicate vaccines. So some things that we can add to vaccines to make them better. So we've got this antigen, it's purified from the organism, it's inducing immunity. How do we make that immunity better? So we have these nanoparticles, but we can also add adjuvants. And so some of the things that make vaccines better are making it more cost effective, fewer doses, right? It modulates the immune system, doesn't activate one side while inhibiting another. Effective innate immune signals, including danger signals. We don't want adjuvants to make our vaccines overreact when there's no invader, there's no pathogen. High specific antibody production. Some vaccines don't produce enough antibodies to actually neutralize the pathogen, and thus are less effective. If you neutralize the pathogen, then you don't have this belief that, well, I got sick or I didn't, those kinds of things. Talked about antigen-specific clonal expansion, so those memory cells exist. Cytotoxic T cells is really important because they can literally kill infected cells and not release the viruses and infect other cells. Long-lasting, right? We want that lifelong immunity. So vaccine adjuvants can help that. And again, less of a dose of antigen. People on the call probably got their tetanus shot. All healthcare providers should have at least one shot, or if they've had a family member who's had a baby, or they've been pregnant. You're supposed to get a Tdap with every pregnancy. And there's a lot of antigen that's required to make sure that tetanus toxoid is protective. We can reduce the antigen by adding an adjuvant or give fewer doses. We actually we have greater effectiveness and fewer side effects. This is just some examples from a paper looking at some of these adjuvants made up of a lot of different things here. There's no quiz on this at the end here. But there are emulsions, there's virosomes that actually contain inactivated virus. It's another way to better specifically deliver the vaccine to the cells to lead to a more natural kind of infection. We don't want to send people to chickenpox parties like I was sent to when I was young. We give people varicella vaccine to protect them from chickenpox so that you never have a disease that in its heyday was killing one child every single day in the U.S. Some of these adjuvants are actually used for currently approved vaccines. AS03, for example, is helping make a malaria vaccine. It was initially thought to be ineffective to actually be effective to preventing maternal malaria and fetal malaria and fetal loss. Let's talk about influenza. So great, thank you for the questions. The global regulation of vaccines. You get a BCG, or essentially a tuberculosis injection in other countries to prevent death from tuberculosis as a child, but it causes you to be positive on your vaccine, on your TB screening test. It's important to know all those different levels of vaccine. So with flu, most of us get inactive flu vaccine. We don't give it to children under 6. It's safe in pregnant women, and it's safe in immunocompromised. So those qualities are great. Important? Yeah, you're giving an injection. You're going to have local and systemic side effects. You can be allergic, although most people with egg allergy can get the inactivated vaccine due to new research. You can very rarely develop autoimmune disorders. There's a live attenuated. It's safe in cystic fibrosis patients. You don't have the systemic allergic reactions, really mild to moderate side effects. Cannot be used in pregnant women, but can be delivered by pregnant providers. There's a recombinant influenza vaccine. This is a very high safety profile. There's no way it can infect you, just like an activated vaccine. It's stable, induces both of those sides of that immune system, right? You always get a better immunity if you have both adaptive and innate, and then the adaptive side, humoral or antibody-derived immune response or cellular immune response, where you destroy the cells that have the virus in them. But here you require adjuvants for it to work. So people may even have reactions to adjuvants, and it's not as immunogenic as the other forms.
So this is the immunization infection.
So in other kinds of newer vaccines, we have a DNA vaccine. So this is all 3 arms. So the more we cover the different forms of immune production, CTLs, antibodies, helper T cells, that's great. You can possibly deliver it mucosally, and then that stimulates innate defense. But there's low level of T cell, B cell memory, so maybe it doesn't last as long. What happens when the DNA integrates into your DNA? We don't know what happens there, other than maybe autoimmune disorders in the worst case scenario. Now, the universal vaccine I've read about and has been studied for over a decade. And what happens is our typical quadrivalent or trivalent vaccines against flu target 3 different strains that change every year, and are based on what circulates in the southern hemisphere during their summer. A universal vaccine targets what are called conserved proteins of all flu viruses, and so you can induce antibodies against this protein that doesn't change, just like the HIV vaccine that was developed. And so you get broad cross-protection for divergent virus strains. This includes pandemic strains. So a universal vaccine says, instead of, some of you may remember the pandemic of 2009, which peaked around Halloween that year, so it was even early, is if you got infected with that H1N1, there is nothing that we could do to prevent you from spreading it, other than social isolation and washing your hands, things that we should always be doing. But this is a way to have vaccine on hand to protect people for longer periods of time against many viruses. Some have said that you can use the universal vaccine every 5 years, and so we'd really have to change how we think about how we market it. It's safe, easy to produce, and stable. We don't require what are called APIs from other countries. And again, in the same formulation, you have both B cells for antibodies and T cells for cytotoxic production. You do sometimes see lower immune responses, and so that's why we need adjuvants along with universal vaccines. And if it's epitope-based, in other words, against that conserved part of that M2 protein, you may fail to predict all the appropriate epitopes. You may see changes in these vaccines. There's a CTL-inducing vaccine and RNA vaccine. So again, there's just lots of things that can be done. So there's a question about the LAIV cannot be used in pregnant women, can be used by pregnant providers. The live attenuated influenza vaccine, the intranasal vaccine, can be administered by pregnant providers, because even if you get it on your hands, or it will not get in deep into the lungs. If it gets into the lungs of someone who's pregnant and thus relatively immunocompromised, it will probably not cause disease because of the way the vaccine's designed. It's called cold adapted, So if it gets into the center of your body, it will be destroyed and not cause infection because it is live, but attenuated, less effective. It's designed to be brought into the body in the relatively colder parts of your nose. So you don't give it to people who are pregnant because out of abundance of safety, but if you're a pregnant provider, you're protected. We just changed to Flu Block. That's the recombinant brand of influenza. How do you know which one is best for a patient? So the CDC provides a very long document on which vaccines are available and which should be recommended. And really, they're only limited by what the FDA range of ages are. So for the live attenuated, it's 2 to 49. Inactivated, it's really anyone over 6 months for many of the formulations. Flu Block, again, is 18 to 65. I think that may have changed. I have to research that. If somebody, one of my students in my class, her brother had a true hypersensitive reaction, very rare, to one of the components of the flu vaccine, to eggs, and a life-threatening hypersensitivity, anaphylaxis, and he got Flu Block. It's approved for those kinds of people. There's some data that recombinant protein-based influenza vaccine has this one paper that shows even better efficacy. So this is where these new vaccines come about. If they work better, maybe we should be promoting them, but we don't have guidance on that because we don't have these direct comparisons in the literature. So here's the thing that I've been talking about for a few years that I'm really excited about. This is the flu vaccine patch. This is a real thing. There's a electron micrograph of the little needles, microscopic needles on the bottom, and then the actual size of the patch, or maybe not the actual size on your screen, but it's a dime-sized adhesive patch with 100 tiny needles to release vaccine as they dissolve in the skin over minutes. I think that we could probably promote this to our patients. So there's one trial here, similar antibody responses to intramuscular injection at a month and 6 months. No serious adverse events. Not surprising that nearly 3/4 of patients, participants in the trial, preferred it to getting an injection. You can even self-administer it. It's heat stable. There's no sharp waste. We don't pay for that. And it's less expensive. So maybe someday, depending on where this kind of technology takes off, October 1st, we all get mailed our flu patches from our various vaccine providers, and we apply them, and we all are protected, and we put it on all our families. Or during a pandemic, maybe we combine the technology from universal vaccines into flu vaccine patches. We all stay away from each other and we administer it. How many layers of skin does it go through? It doesn't go into the muscle. They literally stimulate immunity in the very active immune system that actually exists right under our skin. So we've had various patches. This technology is used to deliver drugs. It's an emerging technology, but they've really, some of these companies have designed this to be directed just directly under the skin. So exciting stuff there. And great for global health as well, whether it's influenza or other kinds of vaccines delivered this way. So there's also ways of novel packaging. So we talked about ways to eliminate sharp waste and the potential spread of bloodborne diseases. We know that we need a 400% increase in cold chain capacity. Cold chain is just, it's very expensive to move refrigerated vaccines and other food and things like that. So if we can create heat-stable vaccines, again, another advantage of that patch, we need to increase this by 2020 because we're going to probably have a malaria and RSV vaccine. RSV is a respiratory virus, very common. There's a vaccine being developed to the World Health Organization. So we need to reduce the volume because every pound of stuff you move has an increased cost. We need dose sparing, needle-free route, and enhanced thermostability. So there are these things called blow, fill, seal, squeeze tubes. If you've ever administered or had administered rotavirus vaccine to your kids, that's what my kids both spit out when they got administered, but I thought what an easy way to package vaccine. There's an auto-disable device using that technology, an intradermal adapter. Again, I mentioned there's an intradermal influenza vaccine, so that's another way. Shorter needles, perhaps easier administration, anyone who's given, a TB test. There's the patches there. There's a disposable syringe jet injector. So if you've ever given those So it's sort of an advanced form of that, those vaccine guns, as they were called, to inject vaccine directly into the muscle. And what's called PAB, which is a fast-dissolving tablet. So designing vaccines that are thermostable, don't require needles, and really are inexpensive to produce and distribute. There's even spray-dry vaccines in two different forms, using a little cardboard device, or people do inhale vaccines. So bringing that vaccine to where infections occur is one way to do it. So you see how it's designed. So lots of interesting technologies there. Okay, so it's great that we have all this investment in vaccines, but it doesn't work if people don't want them. Just as we have people, we have many fantastic medications, and as a pharmacist, we know that people who take them get the effect, and people who don't take them or who are non-adherent don't get any benefit. So look at state-level policy changes, and this is what I study and teach in my class. So when you think about vaccine policies, if you work in healthcare, probably work in a place that has some sort of mandatory or mix of mandatory, voluntary vaccine rules, and these are all state-based. So what types of policies do you think work best to enhance and sustain vaccination rates and ultimately help prevent transmission, prevent deaths, prevent hospitalization, prevent billions of dollars of sick days are lost due to your own illness, your employee's illness, your illnesses of their family, things like that. So let's work on using vaccines to enhance those outcomes. So some of the things that different states have done in this recent review, you can require annual recertification for medical exemptions. So any provider that can provide what's called a medical exemption is this person has immunodeficiency and should not get this vaccine, has to be signed off on. You can educate parents. So a lot of what we're talking about with state-level policies is parents who opt their children out of vaccines. So enhanced education, that's only in 6 states. During an outbreak, some state laws don't allow exempted students to go to school. Some states, majority of them have a grace period, a conditional enrollment period, so that if you're not up to date for whatever reason, it's not that you don't want it, it's just that you don't have vaccines accessible to you. There's a grace period there. I like this one, parental notarization is required for religious or philosophical exemptions. So there's really 3 kinds of exemptions from vaccines that people opt for and that policies address, which is medical exemptions. Those are the least frequent because most people can get vaccines. Religious or philosophical exemptions are 2 other kinds. We've seen a decline in philosophical exemptions, and the biggest deal is when California eliminated the religious exemption, we saw an increase in coverage of vaccines. The problem with exemptions is those who contract the illness that can be bred and get others sick. So it's a belief in what's called herd immunity. The more of us who are protected, the better we protect the people who are unable to be protected. The children under 6 months old, from people under 1 for measles protection. Penalties exist for parents or children who are not up to date. Fines, exclusion from state aid. Australia had such a problem, for example, with vaccine hesitancy, that they have national health care, and if they have a no jab, no pay, they call them jabs in the Commonwealth countries. So if you didn't get a jab, you actually don't get your equivalent of $40,000 a year in welfare. So that really changed people's mind. If it's harder to get the vaccine than to fill out the exemption form, many more people will get exemptions. So if you eliminate exemptions or make it more difficult to get them, we see increases in vaccine rates if you expand the ability of people to get vaccines, just like a lot of health care. I heard South County Hospital had one of the only mandatory flu vaccines where if they refused their subject to termination. Yeah, there's hundreds of hospitals that have that policy. Many states have that policy. And Rhode Island law says that you must either get the vaccine for influenza as a healthcare worker with direct patient access, or wear a face mask during a time when flu is widespread. So, for example, in Rhode Island, flu is widespread now, so anyone who's unvaccinated has to wear a mask. And that's its own hour-long discussion about those kinds of things. What's interesting in the literature there are some court cases where employees have won back the right to work because the labor laws in the state don't allow people to be fired for not getting the vaccination. So this is kind of a complex area, but there are states that do permit termination, and they've lost their court cases based on these other kinds of labor laws. So penalties, it's sticks and carrots. It's, here's the benefit. One study showed that if you paid people to get vaccine, unsurprisingly, more people got vaccinated. And then there's what are called nudges, where if you give vaccine as many opportunities as possible to get people vaccinated, you could almost reach the very high rates that occur when a facility mandates vaccine. We always see the best outcomes when people mandate vaccine, above 95% coverage rates, but there are other ways to do it too that may be effective. So we can refer to ACIP guidelines for vaccination. Provider-led parental education is actually pretty rare. Again, there's 19 states that allow for both religious and philosophical exemptions. So, for example, Vermont and New England just most recently eliminated the philosophical exemptions. Rhode Island doesn't allow it. There's scalable exemptions. Again, what does the form look like? Or a standardized exemption form is in 39 states. There's annual DOH audits. So again, what is, we can pass laws, but who's the authority that determines this? So is there daycare requirements? That's everywhere. Do daycare requirements mirror what happens in schools to get people prepared for that in terms of their the people that are being cared for and the employees? That exists, I know, in Rhode Island. Do exemptions have to be reviewed by the health department for approval? That makes it more hard to get an exemption. There's only 5 states there. Education during the exemption. What kinds of things do you have to watch a video? Does the provider have to sign off on it? Things like that. 15 states allow exemptions during emergencies when there really is something going on. And then 23 states have exemptions during vaccine shortages. Parental acknowledgement is another thing. Physician signatures. Only physicians can sign exemption forms. That brings up sort of what happens when policies change behavior is when California eliminated in sequence their philosophical exemption, which is, I don't believe in vaccines, and then they eliminated their religious exemption because people who said they didn't believe in vaccines then said, my religion doesn't make me believe in vaccines. And I know to everyone listening, most religions do support vaccines, sometimes very explicitly, but you can still claim religious exemptions. And when they eliminated those, there are physicians who are actually selling their medical exemptions to people and charging up to $200 for 6 months of coverage for people's children. So people are paying it, and physicians are providing it. So we have to think about California's looking at their licensing board to say what kinds of medical exemptions are being given, are they appropriate or not, and physicians have lost their license for that. Private schools covered under 40, can't go to private school mirrors, putting the school name on the exemption form, that's interesting, and monitoring the immune status of homeschool children. California says you either take part in our public education or private education system, or your homeschooling is homeschoolers are not required to get vaccinated there. So there's different kinds of policy combinations, and I just took a snapshot of what New England looks like, and you see for vaccination coverage, the policy combinations are more effective in Connecticut and Massachusetts, less effective in Maine, Vermont, Pennsylvania there. We do see decreased non-medical exemptions, and again, this is before Vermont is less effective on that side if they hadn't removed their philosophical exemptions yet. But the problem is that the more that restrictions are placed and the more benefits that are seen when restrictions are placed on exemptions are directly linked to outbreaks of vaccine-preventable diseases, which actually cost more than states paying for all the vaccines for all their citizens. So it is absolutely cost-effective, cost-saving to reduce exemptions for states and to advocate for that. And so you see that there are there's many more bills over the past few years. I just picked Rhode Island and Vermont in terms of the number of bills that are happening. There's Rhode Island had 5 to 9 bills. Those bills are being introduced here, and so did Vermont. And we look at, there were 0 anti-vaccination bills introduced in Vermont, but 5 to 9 anti-vaccination bills and 0 pro-vaccination bills in Rhode Island, or 5 to 9 pro-vaccination bills in Vermont, looking over the 7 years. And when we look at exemptions, they really can be targeted and micro-targeted. It's really different per state, but overall they're increasing. Here I just picked out Maine, which you see there. And when you look at states and counties, and these are the states and you see the counties, there's really incredible diversity in the percentage of non-medical exemption rates. And that's where outbreaks happen in those, on this map, the darker red areas is where there's clustering of non-medical exemptions. Even in Massachusetts, it's not on this chart, in Western Mass, there are kindergarten classes where 25% of children aren't vaccinated or aren't up to date, and so serve as a risk in that environment. Great. As a parent to an autistic child, we have never been shown any proof to vaccines causing autism. That's correct. Vaccines do not cause autism. So you can do further genetic testing, and unfortunately, I think that there are autism researchers who have discovered that it's definitely not vaccines. It's something that happens to children before they're born to cause their autism. And there are autism groups that are very pro-vaccine that help dispel those kinds of myths. Let's talk about vaccine communication. So think about your percentage of patients. Are they vaccine hesitant? How do we reach them? How do we talk about this? As healthcare workers, we may be mandated. That may not be something that a lot of us or our peers like. We must provide the incentive to have a positive attitude here. So it's really a continuum of vaccine hesitancy. When there's high demand for vaccines, people accept them, and then some people, parents or coworkers, things like that, healthcare workers accept some. Sometimes they delay, sometimes they refuse, and then the other end of the spectrum, there's low demand, they refuse all of them. When you look at parents' attitudes, I thought this was a great article that there's the bottom, which is the majority. Majority of parents, is over 90% of parents have no concerns. They have unquestioning acceptance. Some parents and healthcare providers have cautious acceptance. They have minor concerns. Maybe they weren't addressed. Then there's some hesitance. They may not comply with vaccine schedule, may delay vaccines. Then it's selective delay. They're really seeking information. They may be more on the myth side of things, cherry-picking things out of the schedule. And then at the top is this small but sustaining and sometimes increasing in some areas where they decline all vaccines. So again, it's perceived safety. We don't like legislation that limits liberty. We want freedom in this group. There's a thought that pharmaceutical companies are making lots of money off vaccines, and that's absolutely untrue. About 2 or 3% of the total revenue. There's, when I was growing up, I didn't get all these vaccines. Or what's interesting is that young parents of young children probably did get the majority of the vaccines even 20 years ago. So there's all these vaccines. What's going on here? And then professional expertise. We live in a world where expertise is not thought of as something that Google cannot combat or find. Social media. So again, there's these external factors, and really want to emphasize that parent-provider relationship or that patient-provider relationship. We as providers, or the providers we work with, are the most powerful decision makers in terms of, or have the most influence. School immunization requirements, the school's requirement, that's great. The social norm, making vaccines normal. We see these clustering of non-medical exemptions because when exempting your child from vaccines becomes normal, when you have a question and a more vaccine hesitant person says, yeah, you shouldn't go do that because look what happened to my neighbor or my friend. It's that personal anecdote that's really powerful, and they can combat that. So again, the vaccine itself, when nobody knows anybody with the disease, who do you know who has mumps? Who do you know that has measles? Well, in Eastern Europe, there's over 50,000 people with measles because of increased worldwide vaccine hesitance. And then there's just access to vaccines. Race, ethnicity, this just follows access to health care or public health in general. Income, knowledge, past experiences really have powerful barriers. So we look at influenza vaccination. Again, you see some of these things. I'm not going to read everything here. It's the contextual barriers. If you're not offered vaccine at every visit, if that's not on your electronic medical record to remind the provider, if it's not on posters, things like that, that's what's going on there. Yeah, someone says there's a picture on the internet of adults showing all vaccines the child get before they're one. Negative images, I mean, that's how the vaccine, the very, very motivated, social media savvy group of vaccine hesitant and resistant people are. And I would say we have to think about where the person's coming from. We all want our children and our neighbors and friends to be safe. It's just a different perception. And there is a small percentage of people that you cannot get through to. The American Academy of Pediatrics actually put out a report, a white paper, saying if you have vaccine-resistant people and you believe in, of course they believe in vaccines, is to take them out of your practice. I don't know if I necessarily agree with that. It was a recommendation, because then you're not you're preventing access to all kinds of other health care that you can provide. One other comment here, we offer options to come in on weekends with people they feel comfortable with. If they're distracted, they're less hesitant. The ones who flat out refuse, we offer literature, just know not to ask, to just agitate them. Yeah, we see that with myth busting. If you say, if someone really believes flu vaccine causes flu, we all know biologically it doesn't work that way. If you say, I hear vaccines can cause the flu, people will remember the myth and not the solution. So it's always important to think about how we communicate there. So again, there's psychological behaviors, barriers, physical barriers, and socio-demographic barriers for all those things. And this is really what I want to say here is information or searches from the healthcare provider. People who plan to delay or not get a vaccine, the provider changed their mind. Just thought more about it. Information from some other source. So if the pharmacist says it, the nurse says it, the person at the front desk says it, if the video playing in the office says it, if everybody has pins that say, I got vaccinated, if you say, my child got vaccinated, and I believe in this too. It's sort of interesting on this graph, discussion with a spouse or relative is the lowest, so I don't know how influential partners or spouses are here. So this is a report that talks about provider recommendation influenza vaccination status among children. New England is featured under the states featured on those the arrows there. Percentage of children who received a provider recommendation. So everyone was above the U.S. Percent there, 70% hearing it from a provider. So that's really good, but we have a long ways to go. Maine is below 70, and the confidence interval is above there. So we promote trusted patient-centered care, motivational interviewing, always disclose risks. We all know people who probably believe in vaccines, probably know people whose illness is prevented by vaccines, but if they have a sore arm and nobody told them to expect that, they're going to remember that sore arm. If they're fatigued and they're down and malaise, if their child is irritable, they're going to blame the vaccine, and we need to make sure that they're aware and consent for that intervention. If we look at managing parental vaccine refusal, we see a 25% increased uptake in people with vaccine hesitancy with increased access. Again, mandates do work. Patient education, parental education does work. But again, if you correct false information, if you have strong concerns about safety, your intent to vaccinate goes down. In one survey, herd immunity was claimed to be a motivator by a third of patients. We're not sure if that really addresses that hesitancy. And again, you can go into, when I took my kids in, they're still very young. Even my provider said, so which vaccines are you interested in? Is less effective than now it's time we're going to give a shot. Here's your information. Hang here for 5 minutes, we'll be in. Don't give people time. The problem with that in our global quality analysis of all the things we do is that we see higher vaccination rates but significantly lower visit satisfaction because now you're being told what to do. So we're still trying to figure out what is the best combination, and it really comes down to assessing the individual, and there's lots of scales and research that has been done and seeing what the provider wants. Would you think it would be appropriate for me as a healthcare provider to promote on social media the positive outcomes for getting vaccines? Yes. The problem is when you're found out as a person who's pro-vaccine, the anti-vaccine people, I'm very proudly on a list of 30,000 other people of being pro-vaccine on the anti-vaccine, bad list. So I'm happy I achieved that status. But yeah, you can promote it, and you never know if your posts are the ones that tip someone who's hesitant over to saying, well, nurse X or social worker Y or pharmacist B said, you should do this, and here's the stuff. So here's just the study results here. Again, out of over 100 people who, who initiated the vaccine recommendation, the provider, how do they do it? The presumptive was 74%, participatory was 26%. And again, the parent responds well. Fewer resist the presumptive, more resist the participatory. If you're given a way out and you don't believe in it, that's sort of that study. And just another thing too is I think, you may, as a provider or as a provider group, saying, how do we increase our rates? How do we examine the quality of what we're doing? How do we, be the best practice in our state for our Department of Health? With HPV vaccine, where there's lots of controversy in our region and nationally, Rhode Island leads vaccine coverage for boys and girls and first doses and 3 doses. We've always led because we have the most comprehensive mandate against HPV. Of course, that has resulted in a 7 or 10-fold increase in religious exemptions for HPV vaccine. Mind you, there's no religion that says you should not get vaccinated against a cancer prevention vaccine. And as this graph shows out, if you have low vaccine confidence or high vaccine confidence, saying that it prevents cancer is the right message. These are, the best and worst reasons for guideline-consistent HPV vaccination. So if you say it prevents cancer, it's great. Getting it on time, they need fewer shots. That wasn't really there. Your child is due for it. There's more resistance there. Here, I got it for my own child. It was actually not very good at increasing vaccine confidence. There's other data on HPV vaccines that if you offer it consistently, if you're persistent, even those people who are vaccine hesitant or vaccine resistant, between 30 and 50% of that very small population eventually do get their kids vaccinated. And what you have to think societally here is it goes both ways. People who don't vaccinate their child will not vaccinate the siblings of the child. So you create a little cluster of unvaccinated people in one family, in one house. If you can convince the first child or the second child or the parent for one of the children to get vaccinated, you will possibly have influenced, this has not been proven in the literature, that the siblings get vaccinated because you've changed the parent's attitude. Are there statistics that show 2017-2018 morbidity rate with individuals who are vaccinated? Yes, there are statistics. I don't know them off the top of my head, but it was there was, I think, 400,000 excess hospitalizations last year. Again, the worst year for deaths, the worst year for hospitalizations, even worse than the 2009 pandemic year. One thing to think about, I'll end with this, and I'll take more questions here. We ended a few minutes early here. The Anti-Vaccination Society of America in 1902, an association of half-mad, misguided people who write and toil and dream of a time to come where you can keep your body intact. So an interesting study looking at people's political views showed that people who, according to this validated survey, that if you believe in liberty and purity, you're less likely to get your child vaccinated. But if you know that about your patients, you can actually design messages around how that person thinks and say, and so some of the suggestions the authors made were, if you feel that the patient believes that way, to say, being vaccinated keeps you free to do all the things you want to do, and vaccines keep you pure from the illnesses that will keep you home and reduce your liberties. So you stay pure of infection by vaccinating. So you can direct your messages based on what you know. Okay, here we are. Thank you for all your questions. There's one question I think I missed here. Can you, someone should create a doll that shows how many shots a child gets per visit rather than a whole year. That's interesting. Actually, there's a new hexavalent vaccine that just came out that will be available in the U.S., I think, in 1 year. It's been tested in Europe for decades, and so that eliminates another shot. So the more that we can combine vaccines, the more that we can reduce those numbers of shots. But, you know, I'm hoping that when my kids get my grandkids vaccinated, that they'll just be nailed a patch, and you can fit enough vaccine to cause immune reaction with 100 microneedles, then we just slap a bunch of patches on, and won't that be interesting? And then we don't have to talk about resistant malaria causing disease in Southeast Asia, because we have a vaccine that targets parts of that protozoa that don't change, and it doesn't really matter if it's drug resistant or not, will protect it. One thing to think about pneumococcal or pneumonia vaccines, they're so effective that we actually saw a decrease in the rate of antibiotic-resistant bacteria because we were covering so many people, preventing infections in children so effectively. Oh, great. Thank you for the morbidity statistics. I guess I could see if I was actually right on my numbers there. Any other questions? Addressed employees have had the BCG vaccine and the interferon gold blood test. What do healthcare providers do to follow up on their tests? So that's the interesting thing. If you have a patient or a healthcare worker who's gotten a vaccine against TB in the past, you can use specialized tests to see if you have active or passive TB and follow up with chest X-rays and things like that. One more question. There's a great thing with injection. You know it's been administered properly prior to whoever's leaving. Is there a way to ensure the patch is administered properly? It needs to be left and taken off. Right, exactly. So I think those are, that's a great question. I talked about mailing patches. I don't know how long. I mean, the thing is those microneedles dissolve in minutes. So it's similar to how we monitor people who've gotten the injectable vaccine, is we say, wait here and see if there's a reaction for 10 or 15 minutes. If you observe them that they don't mess with the patch for 10 minutes, the vaccine has been delivered. I think that's another advantage from a provider standpoint. So go get vaccinated. That's what I want you to do. Thank you all for listening. And if you want more resources on vaccine communication, CDC is a great site. There's a site called immunize.org, so IMMUNIZE.org has all the translations of the vaccine information sheets. It has all the articles, all the evidence that you can use. It has scripts for how to talk to vaccine hesitant folks. Doesn't have so much on the novel vaccines, but it's a great place there. And if there's any other resources anyone wants, I'm happy to be contacted for that. So back to you guys.
Thank you, Dr. Bratberg. If you wouldn't mind passing the ball to Morgan so that I can just go over the last few slides.
Yep, there you go.
Perfect. Thank you. So these are a few more resources that we wanted to share with everybody. The New England QIN-QIO website, as well as the CDC's webpage on influenza. If you have any questions about anything that was discussed today, you can reach out to Russ Cooney from the New England QIN-QIO. His email and phone number are on the screen for you. And then just a few closing announcements before we end today's call. I wanted to remind everyone that we're now on social media, so you can visit us on Facebook, LinkedIn, Twitter, and YouTube for the latest resources and offerings from the New England QIN-QIO. As you close out of today's webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation now, or you're sharing a computer with somebody, you will receive an email tomorrow with a link to the evaluation, as well as a link to the event page on our website. I did put the link to the website in the chat box. The PowerPoint presentation is currently posted there, and within the next few business days, a recording and transcript will also be added. So thanks again for attending, and we look forward to seeing you on our next webinar. Thank you, Dr. Bratberg.
Thank you. Have a great week, everyone.
Bye.